up, guys? It is Mark from Modern Pain Care, and I am pleased to be with you guys today at lunchtime here in Phoenix, Arizona. And I have a good friend of mine with me today who's going to share an amazing story and some great tidbits. But I want to just kind of go back a little bit and talk how I know Amy. Amy's with us. Amy, where are you at again?
I am in Normal, Illinois.
Normal, Illinois. So I know Amy, she joined our virtual mentorship when Jared Hall and I ran it the first go around our beta group. And I got to know Amy through that. And as I got to know Amy, and she really shared her story because she's a clinician and a patient, which is a great perspective because I think it's good to see both sides of that. And she's going to share a unique perspective with us today. But the more I kind of chatted with her and talked, I was like, man, we need to have you share your story with the group just because I think it's a great story to help us recognize where in healthcare we may, despite, of course, the best interest ideally in mind, that maybe our message and the patient's perception and our message and the patient's, therefore, behaviors after that message can really not be the most helpful thing. So I think we'll hopefully connect those two spheres of the patient and the clinician. Amy has an amazing story. But before we get into that, Amy, do you mind introducing yourself to the folks?
Sure. I'm Amy Eicher, and I do live in a beautiful town called Normal, Illinois. It's as near normal as I get. And I am a pain coach, a PTA. I also have a background in education and a master's in religion. So I have spent all of my life helping people learn different things. So education, faith, and movement are the things that I have taught in the past. And my current path has led me into pain coaching so that I could work with people, hearing their story and having all of the time that I did not have in a clinic as a PTA. So I solved my own problem that way.
No, and that is a huge problem, which we've kind of brought up in this group as far as the time that we need to carve out to listen to people. Sometimes we don't necessarily have that. Ben Palmer, Tony Maritato, sorry, Tony. Good to see you guys. Thanks for joining us. So Amy, I know your story and I think it's an amazing story and have learned a bunch from you just from hearing your perspective and different things. Do you mind kind of sharing your story with pain and how kind of you've, obviously come to an amazing place where you're at right now, but it was not an easy journey for you. I'd love for you to share it with folks.
I would be happy to. I'm going to make the disclaimer that I'm currently writing my memoir on my journey through pain. And even with 260 pages, I can't get it all in. So please know that as I'm sharing today, I picked out parts that I thought would be helpful for people working with people in pain. Contact me, we'll put all that stuff up, but there are so many threads of this story that we can pull on. I just decided to pick out some for you today. So before I even get started, my encouragement to the clinicians that are watching or will watch this is please find your way into a patient Facebook group just to observe. I don't want you to comment. I don't want you to solve. I don't want you to save. I want you to learn and to hear the language that people in pain use in private when we aren't in the room with you. So if you get nothing else from anything that happens in the next 55 minutes, please do that. Okay, so I was in pain for, let's call it 20 years. And have been pain-free, completely pain-free for the last 5.5. Everybody wants to know how that happened. And where that starts is back in college. My pain started as a Division I full scholarship athlete at Illinois State University on the swim team. And I had been swimming through high school, we'll say that. So I was told by very kind coaches that they believed I had Olympic potential. I just didn't want to work that hard. But a swimmer is still a pretty tough beast. In speaking with others that have had military training or fire and rescue, those kinds of things, our mentalities tend to be very, very similar. No pain, no gain. Pain is temporary, pride is forever, littered my bedroom as a high school student and all of the clothing that I wore. A very common phrase that you hear around the pool would be push till you puke. So this was my beginning frame of reference for pain. Pain was something that you did not let get in your way. So early in my freshman year of college, I was having some back pain. There were some psychosocial factors that nobody knew about. I had just gotten away from a man that had been sexually abusing me for over a year, and college and that scholarship were my way out of that situation. It was a secret. Nobody knew about it. But again, you tolerated difficult things to get to better places. So while there is a myriad of things to unpack in that sentence, I'm sharing because it is the beginning of the priming of the things that I believe. So I'm in the pool. I'm having some back pain. I tell my coach, who tells me that I am not paid to go to the training room. I am paid to swim. So the expectations are very clear. I am supposed to keep swimming through the pain. Okay, so I do that. And then one day at practice, I go into a flip turn that I've done 100 billion times, and there is a very audible and feeling that is a snap somewhere in my low back pelvis, followed by searing pain and not being able to move, getting tossed on the deck kind of like a flopping fish. It was very, very uncouth. I didn't like it. A very sweet trainer that was probably very, very excited that something was happening in the swimming pool to treat came along and started stretching. I screamed, and then things get really fuzzy. So I'm not entirely certain what happened after that. I don't think I passed out, but the pain was pretty intense and very everywhere and very, very frightening, because it's not like there's a lot of stories about people having this kind of pain while swimming. We're told what a safe sport it is. I mean, unless we're jumping on each other with really bad start exchanges. But overall, you have repetitive kinds of injuries, not like, hey, something really bad just popped. So that led to a journey of roughly 3 to 4 months of seeing the top specialists in town that treated all of the college athletes. Every scanner that you could put me in, bone scan, CT, MRI, with and without contrast, x-rays. If there was a tube that my body fit in, they put me through it. And at the end of all of this, the very lovely team doctor said, well, we can't find anything wrong with you. It's all in your head. You must just not want to swim.
Yeah.
Okay. So think about that for a minute. I'm 18 years old. It's paying my way. I don't do anything but sleep. I literally have a swim cap right now that says eat, sleep, swim. Still at 44. Like, you wake up, you go to practice, you eat with your team, you go to class mostly with your team. You go to study table with your team. You get back in the pool with your team. You spend all weekend traveling to meets with your team. These people are my family. I don't have any other support structure, meaning, I mean, I'm 18. What else? I mean, I got school and I got swimming, and the only reason I'm at school is so I can swim. So the input that I'm getting immediately from medical providers is that I'm making it up because I don't want to do this swimming thing anymore. I'm totally unable to process that other than just being hurt. Like, it hurts that this is what's being told to me. My coach, who was oh so attentive during the recruiting process, has not called me once since I got injured. So the only person I'm really interacting with are the 2 teammates in the training room with me and a trainer that thankfully believes that I really hurt. I can't sit in class. I can't really walk across campus. Like a 10-minute walk takes me 45 minutes to get to the training room. I'm laying on my back, wishing to God I had a space pen to take notes in my in my lecture halls. So I'm literally laying on the floor with my feet up on my chair, taking notes in pencil on my back, because I can't not go to school. Like, that's not in my framework. I have learned through this abusive relationship that you defer power to those in authority. So this voice inside that tells me, no, I want to swim, I want to be part of this, is really being dampened by the information that's coming at me from these medical providers in authority. So somewhere along the line, my old high school athletic director gets in touch with my parents, says, hey, I've got a therapist up in the Chicagoland area, which is 2.5 hours away. She will take a look at your daughter and see what's going on. So this woman is where my love of physical therapists enters my world. She opens the clinic. I don't know if she owned the clinic. Again, this is an 18-year-old, remember, memories of an 18-year-old. But she opens the clinics for me on the weekend. My roommate is also a friend far back as high school, and she is driving me home because I can't sit that long to drive the car, and is opening up the clinics on the weekend. She has magic hands and encouragement, and uses strain counter strain to fix me. But I will never forget that very first time with her. She listened to my whole story. Every exam, every little bit of it. She just kept asking questions. She touched me, which none of the other doctors had done. And at the end of all of my talking and her prodding, she said, well, Amy, I know what's wrong with you. Well, that was like Christmas. It was like getting a puppy for Christmas. You know what's causing this pain. So if we know what's causing the pain, we can fix it. And the answer to why I was hurting was that my ligaments had torn in my SI joint. My pelvis was unstable, and in all kinds of rotations, I had a right on left sacral rotation, and I wasn't nutating and counter nutating appropriately, and that had caused all kinds of muscle imbalances, and my core was weak. Okay, well, that's a lot, but it's a pathway out, right? So for those listening that use these words, trigger warning, these concepts were very damaging to me in the long run. Not while I was with her, but the conclusions that I would draw based on these words became very, very problematic. So hang with me and keep listening. So I'm unstable, and the center of my body is not solid. It's not strong. It's been damaged, according to this explanation that's been given for my pain. And if I can just make everything really strong, I won't hurt anymore. Now, I will say I was in the best physical shape of my life when I got injured. So when I look back on that, I'm a little confused as to how we drew the conclusion that I wasn't strong enough to hold my pelvis in alignment, and that somehow being stronger than I already was going to somehow make that better. But I'll leave you all to kind of ponder that on your own. And we'll move forward and say that after 9 months of therapy, I did indeed feel better. I was walking across campus in normal amounts of time. I could sit through my classes. My roommate didn't have to give up her bed on the bottom bunk anymore. I was relinquishing my use of a TENS unit and narcotics, and was starting to feel like maybe I would indeed be able to live at least a normal, inactive life. Upon discharge, I was told that I would have this forever. It would come and go, but the most likely outcome is that I was going to need surgery someday to hold my pelvis in place, that I should never swim competitively again, and that I probably should consider not having children. Whew. And then after that, I still had to deal with the sexual abuser and sign away the right to my scholarship because I was told I couldn't swim anymore because of this pelvic instability that was going to plague me for the rest of my life. I believe we could fit that into the category of priming one's neural system. Just as a thought. Mm-hmm. So after that, I did not get back in the water. And I will tell you as a clinician now, I wonder why nobody stuck me back in the pool. It is the only thing I want to do. It gives me freedom and confidence and strength and like all of the things we want a patient to have. And nobody said, hey, why don't you just get in and try out?
Did anybody ask you what you wanted to do?
No.
Yeah.
No. And I find that kind of weird since I'm 18, I'm not working. Swimming is my job, right? So why are we not trying to get the athlete back to her job?
Well, it's of course, because you have a right on right torsion and your pelvis is unstable.
My pelvis is unstable. And
you're a ticking time bomb. Your pelvis could have fell off in the pool.
I destroyed those ligaments with that pop. So clearly
one of the strongest ligaments in the body, by the way, but continue.
Right. And I would like to ask which of the myriad of ligaments is it that's torn that none of the scans saw? But again, never mind. That's unimportant. So we have a lovely primed system that was already threatened by outside sources, right? We have nociceptive input that just absolutely flares out of control. And now I have a narrative that I'm going to carry with me until my mid-30s, that pain equals instability and weakness.
That's going to come back anyway. I mean, it's just a matter of when it's coming back. It's going to...
Right? It's totally coming back, and you're going to need surgery because it's going to get so bad, you're not going to be able to be strong enough to manage it. Well, for those of you with magic 8 balls out there, that is indeed what happens. I'm a bit of a rebel. And so I did get back in the water because it makes my brain calm. Like it calms me. So I spent years swimming and doing these flip turns one-footed and trying to protect my pelvis, trying to participate in other sports, which were apparently okay. Like I could go on point at 30 and nobody's upset about that in my pelvis. It's just the flip turns and the swimming.
I mean, and that water is so much more load on your pelvis than that whole gravity thing.
Right?
Gotcha.
Yeah. So, but I don't understand any of that as a non-clinician that hasn't been exposed to those concepts. So all I know is I keep pushing because pain is temporary, pride is forever. So I go back full force to the gym classes and I can't figure out why I'm in so much pain after them. I must just be out of shape. Because nobody's really talked to me about boom bust and pacing and grading movement and like preparing for flare-ups, because that wasn't part of the story. Go ahead.
And the meaning that those symptoms meant for you. I mean, I think too, as if we think about that whole, what does your nervous system conclude when it gets input from your pelvis? Well, right. I don't think there's any reason to inhibit that signal coming from your nervous system.
No, nothing. Yeah. It's all bad.
All it was like a match, and your brain's full of gas that all these folks filled you up to the brim with. Yeah.
Yes. Yeah. And so between 92 and 2011, every event that increases my butt pain increases this narrative. So there's a car accident, which now I've read online causes SI joint pain. And then I have babies, which increases instability. And I'm a woman, so I get a period every month with relaxin that stretches out my ligaments. I'm hoping that with my animation, those of you listening can kind of see how the innocent things that we say begin to build within a patient. Plug again to go find a patient group and hear the things that you've said so innocently, so meaning to give help and hope to your patient, and watch what happens on the other side of that.
And let me just pause for a second, because how many of you guys watching, and we got about 5 or 6 of us, I know people, it's lunchtime and different things, but how many of you guys have said things that you look back and you cringe? Just give me a yes on that thread below there, if you don't mind. If you've said some things that you want to go back in time and like smack your old therapist or chiropractic self or whatever lovely profession you're in, we've all done it. So let's,
yes. And I've done it as a clinician. I've done it.
I mean, not for malintent, but that's, apparently we should probably update our thinking as science asks us to. But continue. I apologize for busting in you.
Absolutely okay. And actually the next point on my sheet that I'm cheating off of right here is that I had a problem with my story, with the narrative, right? So I don't trust myself because of factors beforehand. I have beliefs about pain that I don't even know that I have, right? So my framework with the narrative handed to me creates an environment that is specific to Amy. Later on, I begin to tease that apart. And when I can see the problem with my own narrative, that's when I start to change my behaviors. So that's what we try to do for our patients, right? We want to help them have a better narrative around moving because we're movement specialists. It's what we do. But I would challenge you that we also have narratives as clinicians. We came through educational systems that believed things. We've taken continuing classes, continuing education that believes things. We hang out online with people that believe things. And one of the things I believe the clinical side needs to do is, as much as we want patients to understand their story, we need to understand our narratives and how we've arrived at them. What do we believe about pain? What do we believe about our jobs? What do we believe about our education? And that takes time, effort, and thought.
Yeah, it's this whole metacognition thing where you have to like reflective practice and things that we are hugely encouraging of here, as far as like understanding some of these narratives that we're taught as truth. That is just absolute truth. There's just no debating it. And we get in our groups and our tribes, and we group with each other, and then we form a Facebook group that shares the one belief. And then if anybody comes in, they're trolls because they're questioning the way I was. I was one of these people. I was very stringent manual therapy. Yep. I had an osteopathic point in my career where I was diagnosing torsions and slips and stuff like that. And you darn well believe that I had some visceral reactions when somebody would dare say that's not how it worked, because that's how it worked. And I think that's a huge thing you bring up, is reflective practice and understanding the story that we bring to the table. Yeah. And not recognizing that story and trying to let it not contaminate the patient in front of us, and recognize our story. We probably need to clean it up a little bit and do an audit of that story to recognize what things, if I think about what a patient may conclude after I tell them they have a torsion or a stuck this or a deranged that or whatever.
Or an unstable whatever.
Unstable. Instability, probably one of my big pet peeves in practice. It's just, there's no benefit to tell a patient that, in my opinion. I don't know. And correct, if you got something that you have down below that you want to say, this helps me to tell somebody they have a derangement or stuck this or stuck that. I know patients want an answer and want a why, but I think there's much better adaptive, less threatening, reassuring whys than the whys that we give to people in the history. But I'm done on my soapbox. Back to you, lady. You keep going.
That's all right. But I do think that as much as we want patients to be aware of their story and what they bring into our offices, we need to be aware of what's up here because it colors our interaction. So I'm not even saying change what you believe. I'm just simply saying know what you believe. Know what you're bringing into these interactions with patients. Because when we start rolling on talking about things like active listening and acceptance and commitment therapy and motivational interviewing and conversing and making sure that our patients understand us as clinicians, we've got to know where we're coming from. And if we know where we're coming from, it makes it a lot easier to interact with the individual in front of us, which is really what Mark and I keep repeating over and over in our particular silo. Yeah. So that's my encouragement, that while it is not something that I can give you that's hands-on, it is absolutely something that you can do for yourself to improve your practice, which will improve your interaction with patients. So I'll tuck my soapbox away and bring you into 2011, where I have now been in bed 20 hours a day for over 3 years. I've had 2 beautiful children. And my pain's a 12 out of 10, Mark. And
did you have anybody tell you that's ridiculous, that it can't be a 12 out of 10?
Of course I did.
Well,
because it's not on the scale, and B, I'm in the office and I drove myself there, so it can't possibly be that high. Mm-hmm. So patient Amy says, please stop asking people that question. It's such a terrible question. Ask them how their pain's affecting them. Ask them how much time they spend thinking about their pain, planning for their pain, working around their pain. Much more helpful information. I don't know a patient that likes giving you a number. What I learned was 9 and 10 are too high. Anywhere between the 5 and 8 range, I was safe. Below 5, I was probably going to get discharged if I started out as an 8. So I'm not telling you anything that you actually need to know. I'm playing the game as a patient, because some of us are pretty smart and we figure it out that, well, I can't tell you how bad it really hurts, because then you're going to send me to the emergency room, which is not what I need. But I can't tell you it's too low, because then you will discharge me, and that is also not helpful. So there's that. But 2011, I am a hot mess that has like when we ask questions like, what do you do for fun? What are your hobbies? How do you move? What are you exercising? How's your relationship with your spouse? How's your relationship with your kids, your family? I got nothing. I got a big goose egg. I'm not moving because laying in bed hurts. I have no relationship with my husband because I don't have anything to talk about, and I can't move. And a sexual relationship had been off the table for a very long time, not because of sexual abuse, but because orgasm involves muscle that would begin to spasm if I got anywhere near pleasure. Well, that sucks. Really wish somebody had referred me to a women's health physical therapist that might have been able to help me with that. But I got kept in the orthopedic streamline. So nobody really looked at that, which to clinicians, I say, these are important questions to ask your people with low back pain. There was an avenue for help that was never shown to me. So yeah, it's awkward. I get it. Put it on a survey that they come when they come in. If that's not your bag and you're not really willing to talk about the pee and the poop and the sex, stick it on a piece of paper and just know it's an option. I found a PT here in town that I adored. Therapeutic Alliance was like, he gets an A+++++ on that. He was encouraging, he was insightful, and he also told me my pelvis was unstable. And we tried for 9 months to stabilize it and get the pain down. That did not succeed. And so he said, Amy, I think this is silly. I think you have tried long and hard enough to do this conservatively. I think you need to look into other options. I said, well, what other options? And he said, well, you could look into prolotherapy or you could look into surgery. He didn't give me a ton of guidance after that, but his facial expression told me that he was not real hip on the idea of prolo. And since I trusted him, I decided I would look into surgery. Now, funny thing, when you've walked with this narrative since 1992 and it is now 2011, talking to surgeons and their PAs about slamming things into your pelvis to keep it from moving is really, really sketchy when you say, well, what about my alignment? And they say, oh yeah, we don't worry about that. But it's my alignment that's causing all of the muscle imbalances, which are continuing the pain. So, and my therapist does this thing, and he been a push and the pull and the tug, and that puts my pelvis back in alignment, and then I don't hurt as bad. So if you fuse my pelvis or fixate my pelvis out of alignment, then aren't you guaranteeing me a lifetime of pain? Because the muscles will never be able to rebalance themselves. So that's what happens to that narrative when it gets drawn out to its logical conclusion in a patient's head. And I will tell you, I'm in several groups of several thousand people that have been told they have SI joint dysfunction, and I am not the only one that came to these conclusions. Now, for obvious reasons, our fair surgeons look at you sideways when you talk about alignment of the pelvis, because they go, you're unconscious, everything relaxes, and it's just in the place that it's supposed to be. But this is not a narrative I've ever heard before. So much like when we hear something that counters our own narrative, I pushed back. That was not something I wanted. I was not going to take the risk of having a permanent surgery that was going to fixate me out of alignment. So I found the one woman in all of the world that has a relationship with the orthopedic neurosurgeon and flew to Georgia to have a PT in the operating room to align my pelvis before the surgery. We can talk about cost and buy-in at a later date, if you like, Mark, but I couldn't fathom having this surgery in any other way than a PT aligning me before somebody stuck screws in me. That was a nice upcharge for anybody looking for a way to make business, but you know. So I'm thinking 6 to 8 weeks, the surgery is going to heal. My pelvis is now fixated in place. It's not fused. I have 3 screws on my left and 2 on my right. Could not get a hold of my post-operative report, which was a little distressing to me because I would really love to see that. But the idea was this was going to stop all this extra movement. I would no longer be unstable. The damaged ligaments no longer mattered because there were screws holding the pelvis in place. And my muscles would now be able to be rehabbed and rebalanced, and I would be able to be strong. Except 9 months after surgery, I was still hurting. And I couldn't understand why, because I had taken care of my greatest concern, right? Taken that off the table. I don't have an unstable pelvis anymore. Again, rehabbed with my fabulous PT with great therapeutic alliance. And now we're really stories of muscle imbalance and weakness. And I don't know at what point somebody's glutes are strong enough to not hurt, was the conclusion that I was drawing through this experience. That, and I really wish somebody had explained post hoc ergo propter hoc earlier in my life. That would have been a good thing to understand. That, you know, well, just because you hurt doesn't mean that it's your weak glutes or your muscle imbalances. And just because you're out of pain, like it's not reasonable to connect all of that. That would have been helpful. But we got to the point where insurance was no longer really willing to carry me because I was ridiculously post-op. Tissue had clearly healed. And I was better, and I was beginning to reintegrate into life, more based on just chit chat than actual intent of my therapist. But I was finding all of those great things that current studies say are important. And it wasn't until I got spit out of the system and I was kind of contemplating why I still hurt, that I was exposed to Explain Pain by Butler and Mosley. Hated that book. Threw it against the wall. I was so angry. Oh my God, I was so angry that there may be another explanation for pain. Like, I don't care if we find out they're all wrong in 5 years and that all of that is just nonsense. I don't even care, because it opened up the possibility that this was more than tissue. And the more I looked into predictive processing, and I like to talk about it as the stories we tell ourselves, right? The more I looked at my story and the more that I dug and dug and dug into the things that I believe, the more I started to confront those beliefs. I wished I'd had a guide, but I didn't. So I did it myself, and I got back in the pool and I started swimming. And you know what? I felt better. I felt stronger. I felt more capable. I reconnected with friends and started, I couldn't do dinner and a movie, but I could do one. So I started going to dinner with my friends again. I started engaging with my children differently. I started making plans for things. I started not parking next to the shopping cart corral to lean on it into the store, and was able to park further away from it. And like, the more that I wrote these things down and reflected on them, the more confidence that I had that I could keep challenging things and moving in that direction. And so over the course of the next couple years, I would basically confront my own beliefs and keep pushing myself. I signed up to go back to PTA school and realized that there's a host of things that going back for an associate's after you've done a master's degree is a challenge in and of itself. But that, I'd been reading papers and research for 18 months and seeing my teachers not really know how to respond to me, not really knowing what to do with what I was saying, really challenging that SI narrative that we were given in school and saying, okay, but allowing clinicians to test my pelvis without knowing that there were screws in them at clinicals, and having the experience of a DO telling me that my left side was moving beautifully, but that my right side was hypermobile. Allowing her to fix me, her telling me I was okay, and then saying, okay, but I have screws in my pelvis, thinking that at that point she would reconsider her narrative.
And just to butt in, I mean, this is, I want you guys to listen to this, because this is how tightly we clutch to our story as clinicians. When we clearly, if we listen to her and we hear what she's saying, and if we hear her story, she obviously didn't on the front end because she just went into treating her, and realigning the pelvis that is fused. And again, so much of that, how we can find things that our eyes want us to find, and how many cognitive biases and things that are involved in that. But listen to what this clinician told her to do. Again, maybe backing up as a clinician, saying, maybe my story isn't correct. But what did your clinician do?
She told me we needed to call an ambulance to take me to the ER because clearly my surgery had failed and my screws must be loose.
Seriously. I mean, and I'm sure this person could be the most wonderful person on earth that I would maybe want to just go out to dinner and have a great time with. So this is nothing personal. And
no, not at all.
Narratives like this as a clinician in my past too. But oh my God, like seriously, I mean, evaluate the words that are exiting your mouth and like think that like, well, it can't be me because I'm a perfect clinician. So obviously this surgeon screwed up your pelvis, and let's turn the fear meter up 4,000 degrees and say,
because you're just a hot mess.
Yeah.
Because your surgery failed. And had I had that interaction, I don't know, 12 months earlier, forget it. I mean, we didn't even mention the period of time where I was suicidal. That would have absolutely, we wouldn't be having this conversation. That would have absolutely driven me over the edge. Like, it just happened that when it happened, I was secure in the fact that my pelvis wasn't going anywhere, and that there were problems with the narrative, and that the research shows us there's problems with the narrative. So I was at least curious enough at that point in the journey that I was like, huh? Now, I did feel like it was unfair that I didn't give her all the information, right? Like, I primed her a little bit by not telling her that I had screws in my pelvis. So about a week later, I told her I didn't need an ambulance and I wasn't in any pain. So it was all going to be okay. But a week later, I came back and said, have you given any more thought to what happened in the clinic? And she was like, I still think you need to go see a doctor. You need scans. That's not right. So I was hoping with some time she would be able to back up and reflect from like the absolute door in the face that I had just given her.
Yeah.
But
and it's just these narratives become so ingrained in us. And that's where, like, Jason and I had discussions and others. Yeah. We should never be defined by an intervention or defined by a system of like treatment. Because then again, the patient, is a secondary thing of that. It's the system. It's my treatment. It's my process. I speak at my yearly conference that's focused around my system. And it's everybody I interact with who shares that same belief and just strengthens my system to the point I don't even listen to my patients anymore because it's my system that I listen to, and it's my system that drives my decision-making. I don't need the patient's story because I have the system. And this is a recovering system guy here, so I'm not by any means claiming innocence to that. But man, I mean, and a good example too of how our hands they can tell us a lot of things that aren't there because we're trying to find things, and probably motivated on some amazingly good things. She wanted to help.
Oh my gosh, yes.
Not like she was trying to
She was trying to teach me, and then she found something, so she was going to help me. Like, there is no ill will in this story anywhere other than me being mischievous,
Well, and I mean, it's just a good example of how those narratives are just littered with bias and just so many things that I think we have to just, again, like you beautifully stated, we have to know our story coming into there and be willing to put our story through some scientific scrutiny too. Yeah. I mean, you've clearly pointed out as well that there is not a lot of science to support that narrative. Yet because it's become such a accepted part of this treatment fabric and accepted part, like
it's part of
this accepted truth that we need to buck this truth. It's a lot of it is a lie. Now, I'm not saying there isn't times where traumas to the pelvis, pregnancy, there are times and there's some support for it.
Times.
Yes, but it isn't everybody walking through your clinic, which we see this, it's amazing. Certain systems find a lot more of this thing. That's definitely
than other systems
tends to find a ton of.
And to go from the place where I was completely certain before that surgery that, okay, well, if you've gone on this long and you've had the injections and you've done the things and you've followed, the diagnostic flow chart and you haven't gotten relief, well, then you just need to be aligned and surgically slammed together. I mean, I was the queen of telling people that they were going to die if they had surgery with another surgeon in a different part of the country. So I am just as guilty on the patient side of driving that narrative. And as we explore our own stories, we're still creatures that are biopsycho and social. And what you just pointed out is that's part of the social narrative, right? Like, it's just common knowledge in manual therapy. And so again, I say we need to examine that. And I really want to reinforce that, like, I am telling a story that I know thousands of men and women are telling. It's not like I'm just kind of this, I am an N1, but I'm not the only one that takes this arc and ends up at this same conclusion. So it's 2012, I'm back in school. I'm angering my teachers with my challenging, and then I end up as a clinician trying to be less wrong and championing patient story and listening. And I will tell you that I am now the proud swimmer again, and challenged my own narratives, went to CrossFit and like blew my own mind with what I was capable of. And I decided if I can back squat, I can probably hit a flip turn with some serious speed and be okay with that. And kind of the closing out of my personal physical journey was I went back to swimming in the fall with the intent not just to swim for enjoyment, but to actually train for something. With the added benefit that I will be in Mesa in May or in April. So you and I have a date then. But I qualified for nationals at my first meet back, totally out of shape, gasping for breath, half dead. And I still managed to have some oomph left in this bod. So no clinician got me there. That was me pushing myself and stripping away all of these stories that had been told and returning to a place of authenticity and resilience in my own narrative with myself.
Yeah, no, it almost pains me to hear people who have to leave healthcare to get better. And that's where I think you could say healthcare, because I mean, come on. I mean, and we've talked already about how we've given narratives, and I don't think anybody can claim innocence because we go by the best information we have at the time. But again, more reason why, especially with social media and the internet, our information ability to stay up should be a lot easier than it used to be when you had to go to the library and like manually photocopy journal articles and all that stuff. Yeah, I mean, just a crazy, frustrating thing that, and unfortunately, I work in a similar DO setting, and I can't tell you how many times I hear that narrative, and it's a huge barrier. It's a huge, huge barrier, and it's a delicate barrier to navigate as somebody who's part of a team that's trying to. So it's a lot of education within things, but there's some stories that aren't ready to be challenged, and I get it. There's parts of my career where if you came at me, I would probably be that troll on Facebook.
Oh, absolutely.
That's going to tear you up. That's going to tell you you're just not as good as I am. That it's just, you don't have the skills I have. You
just don't have the skills. You can't. You're unaware of the things I'm aware of. And Anthony Lowe is actually the clinician that started pushing up against my narrative. And when he started with me, oh my God, I was angry. I had just finished reading Explain Pain, which blew my brain against a wall, especially reading that as a non-clinician. And then, I kept saying, show me, show me, show me. And then as papers started coming across, again, still not a clinician, just an insanely curious patient. And, I always get the name wrong. Is it Tallberg? Tallberg. Hate that paper. Blew my brain away. Like
that manipulation doesn't alter the position of the SI joint?
Right, which is what led to that experiment with the DO, and then having the actual life experience correlate with the paper, I was like,
yeah.
So I needed a new framework. I needed a new framework to understand things, because I rapidly figured out, well, I can't go around telling patients these stories because this isn't going to help them, and then they're going to end up in places that I ended up.
Yeah.
And that was really what started my journey digging through pain science and all of the spider webs that go out from that. I still hate the term.
So we're in the process here at our university of trying to flip our curriculum a little bit to, they talk about it like International Association for the Study of Pain, Daniel Carr and others talk about flipping things to be social psychobiologic frameworks. And it's your story kind of rings of that, as far as it wasn't biologic things that got you back to you. It was you reemerging into life again. It sounds like you got back in the pool. You did things, and you changed your thinking a bit around it. You got your thinking challenged, and it was uncomfortable, which it normally. But I still see a propensity in our profession to still pull it into the biologic narrative. We just have this default of we have to name it and label it as a tissue or something. And I'm probably still not as good as I'd like to be, but I just think sometimes get people back to life. Quit making it so complicated. And it doesn't need to be a fancy muscle imbalance. It doesn't need to be a fancy trigger point or some amazingly complex manual intervention or assessment that you did. That I've noticed that when I focused on the social psycho part, as far as let's get you moving in ways that are important to you to get back to what you enjoy in life.
Right. And I
my
get
outcomes are, if anything, better. There's still times where I treat tissues because we know that still happens. I'm not saying I've abandoned, because that's where I get. Well, Cargil is just talking to people all day. He's throwing away treatment tables. He's just chit chatting with patients all day. I still do a lot of exercises. They're not nearly as complex as they used to be. As far as I'm not worried about standing on a Swiss ball holding a red band and doing a a body blade while I'm trying to do some crazy.
I will tell you though, that like that was definitely the bent of my clinician. And I will tell you, looking back through journaling, that's where I'm like, I felt like an athlete again. So
yeah,
like it, you know, how often do we say it may not be, it's working, it just may not be for the reasons that you think it's working?
Sure. That's a great point, because I do think sometimes we have this natural bias to ascribe it to our story is the reason.
Our story.
But there's a lot of things that surround our story that, because we silo our thinking into our neat theories and our neat belief systems, that there's a lot hanging out around that silo that are probably moderating the outcome a lot more. You started seeing the old Amy again by doing that stuff. Even
by
though the
doing
exercise, you know, I saw Adam Meekins, my buddy, posting, and there was a gentleman on Instagram who's doing some absolutely off the wall bonkers functional exercise. I still haven't decided if this was a spoof account or if
like
he's
if
really
it's
doing it.
sarcasm to make a point.
Yeah, I mean, but apparently I'm still not, the discussion on social media is still up in the air whether it's a real account or not, or there's real. But again, and then you see people probably some people love it and dig it and get into it because they're seeing a lot of empowerment of, look at all this crazy stuff I can do. That maybe we don't need to there's a lot less of the mechanical complexity. There's a lot of social, psychological complexity that rotates around a lot of our interventions as well.
Well, I think the clinician side of me wanted a structure and a framework to be able to start to process how to deal with the individual in front of me, right? Mm-hmm. So those systems are important to our work. Mm-hmm. We have to, because if you just said, okay, we'll just deal with the person in front of you, to the brand new grad, their heads are exploding all over the place. They need something to be able to move from point A to point B on. But I think just like a patient needs to evolve, clinicians also need to be able to evolve. So we start with a structure and a framework, and then learn that there are others, some that you're going to agree with, some that you're not. But you have no idea the other clinicians that patient has seen and where they're starting. So education, religion, psychology, there's more than one school of thought on how and why stuff works. And our field is no different. And by exposing ourselves to those other theories, we get a broader picture, which should enable us to be more flexible with our own narratives as clinicians, which in turn allows us to respond to the individual in front of us.
And as clinicians, we need to write our stories in pencil, not in like black permanent marker, and be willing to erase and rewrite our stories. I just think we get so ingrained in our stories as clinicians, and in our nature is to just group up and like really get fired up about this story. And, you know, like I already said, we have conferences around this story, and we all slap each other in the back because it's our story that's got it all figured out. And then
that's right.
Then there's patients that story resonates nothing with, that story could cause harm to the patient based on some of the language around it. And I just think, you know, science, being a true reflective clinician and the science-based clinician demands that you have the ability to update your thinking. It should never be written in permanent markers. It should always be, you know, and always be scrutinized. If you're ever...
And changing. We should always be growing and changing, because I stayed stuck in my narrative for so long. Mm-hmm. Like I didn't know that there was another possible way to think, right? Like I didn't, as a patient, I didn't know. As a clinician, I know there's a lot of different ways I can approach movement in the human body. Yeah. And we can only take the next step with what we can see. And so if we're willing, either as patient or clinician, to open up our mind to what else may exist out there, that's how we keep moving forward.
Yeah. And that's kind of what we're doing with our programming and stuff, is just really giving people a process where you can take different products or systems or treatments,
right?
But they have to go through a process. It has to be a way that you can clinically reason and think and ascribe that treatment to scrutiny that you would ascribe to any treatment. There's no biases. If you have biases, you're going to examine your biases, you're going to declare them, and you're going to recognize them. And it's okay to have them. We all have them.
We have to have them. It's how we function.
Yeah, bias is, we wouldn't be able to make any decisions without a bias.
We have to have predictive processing. We have to have crime systems. We have to have beliefs. Otherwise, we can't make decisions.
Exactly. Well, Amy, we could chat for another good hour and bang the drum and do all the things. I really, really appreciate you sharing your story with everybody. I hope you guys out there, Ben Palmer, I see you're on here. We will definitely invite you out for a beverage when Amy's in Mesa, because Ben's here in town right close by as well.
That's right.
Again, I can't thank you enough for sharing your story, and I love what you're doing over there at Restoring Venus. If you guys have not seen Amy's stuff over there at Restoring Venus, definitely check it out. She's writing a book. She's helping a lot of people out. She's going to be an amazing resource where if you have patients who are struggling with a story, send her over that way and send them over to that.
Let's work together, because I know you don't have time in the clinic to dig out all the stuff that I can dig out.
And it's amazing how much your clinical work gets so easier when the story starts aligning and somebody's helping you from the exterior. So can't thank you enough, Amy. Thank you so much for your time today.
You're welcome. Is it okay if I drop a link to sign up for my memoir in the chat?
Yes, we are full support of your memoir and supporting your story and getting it out to more people. I think the more people that read your story who might have been down the same path, that hopefully can pull some people out of the weeds and get them on a better path sooner. So definitely do it.
Fantastic. I am hoping to have a workshop up and running for patients and clinicians on thinking in the next 4 to 6 months. So
love it. Keep us posted on it.
Will do.
All right.
Thanks for having me on, Mark. This was awesome.
Yep, no problem. You guys all have a good day. Thank you for tuning in, and we'll keep an eye out. We got more content coming on Thursday. We got later today, we got Jared Hall's going to release 3 lectures that he recorded, and then Thursday we're going to talk about CRPS. Actually, it's going to be Wednesday. I don't prefer to have live streams on Thanksgiving. I think my wife would probably divorce me if I had a live stream on Thanksgiving, and she should if I did. But so stay tuned for that stuff. And then December 11th, we're going to have the big program announcement where we're going to teach everybody the very process that we're talking about here today. So you guys all have a good day, and we'll see you online.